Polycystic Ovary Syndrome, PCOS, is a common endocrine disorder affecting women of reproductive age, characterized by a spectrum of symptoms including irregular menstrual cycles, hyperandrogenism, and polycystic ovaries. Among the various metabolic disturbances associated with PCOS, insulin resistance stands out as a significant contributor to its pathophysiology. This video delves into the intricate relationship between PCOS and insulin resistance, examining the underlying mechanisms, clinical implications, and therapeutic interventions. Understanding PCOS and insulin resistance. PCOS Overview. PCOS is a multifactorial disorder with genetic, environmental, and hormonal components. It affects approximately 6–12% of women worldwide, making it one of the most common endocrine disorders. Diagnostic criteria typically include hyperandrogenism, oligo-anovulation, and polycystic ovaries on ultrasound. Insulin resistance. Insulin is a hormone produced by the pancreas that regulates glucose metabolism. Insulin resistance occurs when cells fail to respond adequately to insulin, leading to hyperinsulinemia as the pancreas produces more insulin to compensate. It is a key feature of metabolic syndrome and type 2 diabetes. The interplay between PCOS and insulin resistance. Hyperinsulinemia in PCOS. Women with PCOS commonly exhibit hyperinsulinemia, even in the absence of obesity. Insulin resistance in PCOS is postulated to result from defects in insulin signaling pathways, including impaired insulin receptor function and downstream intracellular signaling. Effects of hyperinsulinemia. Hyperinsulinemia exacerbates ovarian androgen production by stimulating theca cells and decreasing sex hormone-binding globulin (SHBG) production in the liver. Elevated insulin levels also directly affect ovarian follicular development and contribute to anovulation. Implications for metabolic health. Insulin resistance in PCOS increases the risk of developing type 2 diabetes, metabolic syndrome, and cardiovascular disease. Dyslipidemia, hypertension, and central obesity often accompany insulin resistance in PCOS, further escalating metabolic risk. Mechanisms underlying the PCOS insulin resistance link. Lipid metabolism. Dysregulation of lipid metabolism in PCOS contributes to insulin resistance. Increased lipolysis and elevated free fatty acids impair insulin signaling and exacerbate insulin resistance. Inflammation. Chronic low-grade inflammation is prevalent in PCOS and contributes to insulin resistance. Adipose tissue-derived cytokines, such as TNF-alpha and IL-6, promote insulin resistance by interfering with insulin signaling pathways. Oxidative stress. Oxidative stress, characterized by an imbalance between reactive oxygen species, ROS, and antioxidant defenses, is elevated in PCOS. ROS impair insulin signaling and contribute to insulin resistance by promoting inflammation and lipid accumulation. Clinical implications and management strategies. Diagnostic considerations. Screening for insulin resistance should be considered in all women with PCOS, especially those with additional risk factors such as obesity and family history of type 2 diabetes. Measurement of fasting insulin levels, glucose tolerance tests, and calculation of the homeostatic model assessment of insulin resistance, HOMA-IR, are commonly used diagnostic tools. Lifestyle interventions. Lifestyle modifications, including dietary changes, regular exercise, and weight loss, are first-line interventions for managing insulin resistance in PCOS. These interventions improve insulin sensitivity, reduce hyperinsulinemia, and ameliorate metabolic risk factors. Pharmacotherapy. Insulin-sensitizing agents such as metformin and thiazolidinidiones are commonly used to treat insulin resistance in PCOS. These medications improve insulin sensitivity, regulate menstrual cycles, and reduce androgen levels, thereby addressing both metabolic and reproductive aspects of PCOS. Emerging therapeutic targets. Novel therapies targeting underlying pathophysiological mechanisms, such as anti-inflammatory agents and antioxidants, show promise in the management of insulin resistance in PCOS. However, further research is needed to evaluate their efficacy and safety in clinical practice. Conclusion. In summary, the link between PCOS and insulin resistance is complex and bidirectional. Insulin resistance contributes to the pathogenesis of PCOS through various mechanisms, exacerbating hyperandrogenism and menstrual irregularities while increasing metabolic risk. Understanding this relationship is crucial for the comprehensive management of PCOS, encompassing both reproductive and metabolic aspects. By addressing insulin resistance through lifestyle interventions and pharmacotherapy, clinicians can improve outcomes and reduce the long-term health burden associated with PCOS. Further research into novel therapeutic targets holds promise for advancing the management of insulin resistance in PCOS and improving the quality of life for affected individuals.